I think it's a few minutes past 9. So, dear colleagues, welcome and good morning to NeoFOCUS' Friday weekly presentation. We have Professor Arvind Sehgal again, luckily for his second lecture. And I'm going to let Dr. Jay Banerjee introduce him, as I am sure new people have now joined in. So Jay, please introduce us as Professor Sehgal. Thank you.
Thank you, Ahmed. Professor Sehgal is a neonatologist at the Monash Children's Hospital and Professor of Pediatrics at the Monash University in Melbourne, Australia. He has been the head of cardiovascular research at Monash for the past 13 years, 14 years, I think now. He's completed his PhD in 2016 whilst working as a full-time intensivist, and is currently enrolled for a doctorate degree in perinatal hemodynamics program. In 2019, Professor Sehgal's research was awarded the ANZNN Emerge Respiratory Research Award, and he was awarded the Professional Excellence in Research Award by the university for the year 2022. So Arvind has been a member for the award selection committee at the American Academy of Pediatrics and has conducted and chaired invited hemodynamic sessions at the Pediatric Academic Society meetings held in the US. And his current research focuses on cardiovascular adaptations in infants with severe DPD and those with fetal growth restriction. He has several hundreds of publications around this topic in international journals. And so last Friday, he talked about broken hearts. And today he's going to talk about the aging vessels. Professor Sehgal, please take it away.
Thank you very much, Jay and Ahmed. It's a pleasure to talk to you guys again. And my apologies that it's morning time in England. So I'm sure you have better things to do. So it's more of a continuation of last week's session. And I'm really going to focus on the arterial circulation today. And things which are in red I've covered already last week. So I'll be talking about the clinical consequences of what happens in the arteries, what we know from fetal ultrasound in terms of blood vessels. Is there data from placental histopathology that can tell you before the chronic issues set in on the day of birth? Can that tell you what is going to come in future? Why it happens? What are the mechanistic and epidemiological links? Briefly, animal data which corroborates what we see in newborns and children and adolescents and young adults. How it can predict, how the information we can get in the perinatal period can predict what will happen in adulthood from the vessels, and time permitting a bit on the therapeutics. So as I said last time, there are various definitions of fetal growth restriction in the literature, but for the sake of today's talk and all my studies which I would be presenting, this is the definition I've used, which is birth weight less than 10 centile for gestation and sex with abnormal antenatal Dopplers. So from the heart, we learned last week is that in fetal life and neonatal life, conventional echo parameters can tell you there is dilated heart, there is septal hypertrophy, there is diastolic dysfunction. So the first function of the heart which gets impaired is the diastolic function. And if pregnancy progresses and the growth restriction persists in terms of uteroplacental insufficiency, the systolic function in terms of cardiac output also gets impaired. So it's the diastolic function which is more sensitive to the effects of intrauterine growth restriction. More than conventional parameters, there are strain echocardiography, which is something which has been there in the neonatal field for last 10 years, but adults and pediatrics, they've been using for about 15, 20 years or so. And that information is accompanied by changes in cord blood biomarkers like troponin and BNP, which tell you, even at the time of birth, that these hearts in utero were quite affected. So this is a figure which I created some time back, and of course the uteroplacental insufficiency chain of events affects the heart primarily, which is in the middle, where the myocardial architecture gets altered. There is a lot of glycogen and collagen deposition. There is fibrosis, so the heart doesn't function as well as it should. But at the same time, and maybe uh, in preference to the heart, the circulation is also affected. So there are changes in arterial structure and tone, and I'll show you some data that which tells you that even before these babies are delivered, on fetal ultrasound, you can see the changes in the arteries in terms of thickness and stiffness. And when these babies are delivered, if you check their placenta, you already see there are changes in blood vessels. So these are effects, chronic disease, which is starting in the fetal life. So it's the fetal origin of adult diseases. That's the reason why that name has caught up. So this is the original paper from Professor Barker in 1992 about fetal origins of adult hypertension. And in the text of that paper, there are one or two lines which are, I mean, this is really early 90s when ultrasound was not that advanced technology, but there is a mention that possibly there are changes in blood vessel structure or blood vessel compliance, which could be, underlying this adult hypertension. So when I read that paper, these two lines caught my eye in, I would say, 2011 or so, and we thought we'll just look into that a bit more detail. And this is our more recent work, which is a collaborative work with people in the US who sit on the committee of the American Heart Association. And what we were looking in this Journal of Pediatrics paper was that there are various reasons, various mechanistic links between growth restriction and hypertension. But our focus is going to be early vascular aging. So those who are interested in this multi-factorial, multi-dimensional links between the two entities, encouraged, seek out this paper, which talks a lot about vascular aging, but also talks about other reasons why this problem occurs in these babies. Now, Professor Barker's work was in 1992. We started work in 2013. But if you look back in time, people have been interested in stiffness compliance, major artery biomechanics since late 1800s, even before we knew something called hypertension even exists. And hypertension, as you know, it's a leading cause of death amongst all cardiovascular disease risk factors, with more than 100 million affected in one country itself. So it's important that we take a step back and look at risk factors which can put these people at a higher risk of developing hypertension. So beyond the conventional risk factors like sedentary lifestyle, high salt intake and family history, is there anything else? And I'm not a general practitioner, but my wife is, and clearly when people come with hypertension, nobody ever talks to them about perinatal history. The questions are about, smoking and alcohol and other things. So it's important for us as neonatologists, as well as, epidemiologists and cardiologists, and those in public health, to understand that this entity is an important risk factor as well. We talk about what we define as fetal growth restriction and how common it is. In Australia and New Zealand, in term infants, it's about 9%. Overall, around the world, ranges between 5 to 15%. But as I mentioned last week, amongst premature infants, the incidence is about 18 to 30%. So the burden of disease is immense in this population. Now, the links between growth restriction and high blood pressure in later life. So this association is starts very early. You know, I presented some data last week about term infants, studies on term infants, comparing IUGR with AG infants and showing that the IUGR group had a higher blood pressure compared to AG newborn babies in the first 2 weeks of life. They were not hypertensive, but they start tracking at a higher blood pressure very early on in life. And this tracking becomes really strong as early as 4 years of age. And you tell me, if you have children, you've been to a GP or a pediatrician, have they ever actually measured blood pressure on young children who come to their clinic? And this association between birth weight and high blood pressure is across age groups, and it's independent of body mass index. So it's independent of BMI. So it's not that an obese child would be hypertensive. That's a misconception. The link between what happened during fetal life and blood pressure is independent of that particular variable. So it's important for us to understand why this happens, and that will tell us, what are the therapeutic approaches we can use. The other two concepts I alluded to last time as well is about catch-up growth. So if parents have a baby who looks small and skinny without much subcutaneous fat, and their intention is, of course, this baby has to be fed in such a way that, becomes bigger is better idea. That's not particularly true. If you look at information, the mean 24-hour ambulatory blood pressure in adolescents, that's highest when you combine growth restriction with later obesity compared to normal birth weight or compared to FGR without obesity. So this double hit not only affects the heart in terms of cardiovascular morbidity later on, but also affects this blood pressure um, concept as well. The other issue, which is thrifty phenotype. So this theory proposes that during fetal life, the fetus is deficient in a particular essential factor, which leads to crucial organs getting maladapted, but that maladaptation comes at the expense of other organs which are considered less significant for survival. So this would affect the brain, the heart, and adrenals. So they maladapt, and in a setting there, in terms of nutritional deprivation, there is a deficiency of an essential factor. So that's what this theory talks about. So let's start our journey from fetal life. So the whole idea is about being precise in prediction. If you're starting very early in life and talking about diseases which will turn up at 6 months of age or 6 years of age or 50 years of age, and you really want to be strong in predicting that and precise. So this study from the Spanish group, they evaluated fetal echocardiography and parameters to whether they can predict hypertension and arterial remodeling 6 months after birth. Okay, fetal echoes, but the outcomes they're looking at is at 6 months of age. And their definition for infant hypertension was at 6 months, mean blood pressure to be more than 95th percentile. So they compared 100 FGR fetuses and 100 well-grown fetuses, and they defined arterial remodeling to be more than 75th percentile at 6 months. So there are nomograms established, which I alluded to last week, and I might actually talk about that this week as well. So they are a range of parameters they looked at. I'll break them down. So these are the conventional parameters you look at. Of course, you look at gestation age, you look at birth weight, and then the obstetricians look at, these uterine artery pulsatility index, umbilical artery Dopplers, cerebral placenta ratio, ductus venosus pulsatility, and aortic isthmus pulsatility indices. And they were looking at a univariate analysis to which of the echo parameters or clinical parameters are significant in predicting hypertension and arterial remodeling 6 months down the line. Okay, so first important thing you see is gestation age and birth weight. They don't give you too much information. Ductus venosus, which is considered almost a pre-terminal ultrasound parameter in fetal life, not significant at all. And same as with the aortic isthmus pulsatility. But when you go beyond the usually measured parameters and you start looking at the baby's heart, the size of the chambers, the sphericity, the thickness of the walls, not so much the systolic function, but you look at here at the bottom, diastolic function. So these parameters, diastolic dysfunction in the fetal echo and the shape of the heart, they are very sensitive in predicting what will happen 6 months down the line. So using these parameters, they created a cardiovascular risk score, right? So this score, this is how it looks like. And this cardiovascular risk score in fetal life could identify uh, within these IUGR fetuses a subgroup which is at the highest risk with a sensitivity of more than 90% to develop hypertension at 6 months of age. So as I mentioned last week, that if you work in an area where you see 100 or 200 IUGR newborn babies every year, and you are resource limited, and you really want to identify out of those 200, which are the 25 which are the highest of the highest risk. So this is one way of sorting them out, that if you really want to follow them up later on in terms of morbidity, mortality, or what happens to their heart and vessels and growth, then this is something which is going to help you to say, okay, within that high risk group, I've got a smaller group, a subgroup, which from the hypertension point of view is at a higher risk as compared to other IUGR babies. And if I can compare all these parameters together, on the top are the perinatal factors and the commonly measured indices. Again, you can see that the association between birth weight, gestation, and hypertension is very weak. Fetal Dopplers, which is what we currently use, you work with obstetric colleagues, they say, okay, we are going to deliver this baby because the ductus venosus Dopplers are abnormal or umbilical artery Dopplers are abnormal. They have association with perinatal outcome, and that is why those deliveries are being done on a priority. But if you look at postnatal cardiovascular system outcomes like hypertension, they are weak, right? So it is the fetal echo parameters, which I mentioned here at the bottom, especially the diastolic function parameters, they have a strong association with cardiovascular morbidity, hypertension, and arterial remodeling going forward. Okay, so if your focus is to look at this as an outcome, then these birth weight and the commonly studied fetal ultrasound parameters are not going to tell you. They're certainly good for perinatal outcome, but not for morbidity, cardiovascular morbidity 6 months down the line. Okay. Now, last week I had mentioned that the most common parameters which are used in neonatal medicine for the cardiac contractility are the ejection fraction. And again, this fetal study tells you that ejection fraction, while commonly used, is in terms of utility for prognostication is actually quite useless. So never be satisfied by only using that parameter. So we have been interested in blood vessels for about, I would say, 11, 12 years now. And there's some studies which are on the slide here. Looking at the placenta, as I mentioned, an area of interest is what happens during fetal life certainly can very strongly reflect in the placental histopathology. So this is our work which looked at 20 FGR infants with 20 AG infants of comparable gestation about 29 weeks. And we sent placental histopathology interstate to a histopathologist who was an expert in placental histopathology literature, and of course blinded to which slide belonged to which group. And they used standard placental workshop consensus statement classification. And what they noticed was that there were certain features which were there in the placenta of FGR fetuses, which are significantly more common. And all of them were looking at the blood vessels. So maternal vascular malperfusion, villus maturation, fetal malperfusion, not so much so inflammation parameters, but vascular abnormalities. So certainly there was evidence of involvement of the vasculature even before the baby is born. It's very important. Now, I talked about fetal ultrasound and about can they measure the thickness of the aorta before the baby is born. So this study was looking at 32 weeks FGR gestation singleton fetuses and measuring the aorta intima media thickness. And they looked at a correlation between fetal assessments and at 18 months. So in the group in which the aorta was thicker at 32 weeks gestation, there was a correlation when they made assessments at 18 months of age in that cohort. And certainly, systolic BP was significantly higher in the FGR subjects. And in addition to that, significant correlation between prenatal and postnatal thickness of the aorta. So this is one of the studies in which it's like a serial follow-up has been done of the same cohort. But a lot of other studies I'll talk about are more cross-sectional. For example, studies between 8 and 13 years, young adults, adolescents, all showing increased stiffness, higher central pulse pressure, and higher impedance in cohorts which were born growth restricted compared to non-growth restricted cohorts. So what essentially I am trying to say is that there is a differential path or trajectory which gets identified in terms of blood vessel architecture and how those blood vessels look like under the microscope and how they behave on ultrasound. And that predisposes to cardiovascular disease risk, especially hypertension later in life. Now, those who are interested in finding out which are the commonly studied indices, this is a summary of a work in I think sometime back. We look at the thickness of the aorta, we look at how stiff it is, we look at the impedance, vascular resistance, pulsatility, and compliance. And so these are all ultrasound parameters which are validated in the pediatric population, and we summarized this in this paper in the Journal of DOHAD. I can't remember which year, 2016 or so. So if those who are interested in this, they can always tap into that. So looking at the neonatal literature now, moving away from the fetal life, this is our work in Journal of Pediatrics 2013, where we comparing the thickness of the aorta. These are the AGA group infants. These are the IUGR in the first column. There's the AGA group, and you can see here the thickness of the aorta, stiffness, impedance, elasticity, systemic resistance. They're all very different compared to the AGA group. And if you spread out, so these are 20 infants in each group, as you can see here. This is where 650 odd is the normal at 37, 38 weeks, and in FGR infants is coming out to 850 or so. Some are even higher. And these were infants who were not less than 10th centile. These were less than 3rd centile for gestation and sex. And then the question was about, okay, these are delivered at 38 weeks. If we move the goalpost a bit earlier, are there changes even in premature babies? So this is a cohort which is around 30 weeks gestation. As you can see here, small babies compared to AGA babies, and blood pressure, of course, is higher in this cohort, not in the hypertensive category, but still tracking along on the higher scale. And these assessments were done in the second postnatal week of life, close to around 10 days of age, once the duct was spontaneously closed. And all these infants were on CPAP, so none of them were mechanically ventilated infants. Again, you see a very similar picture here that in FGR infants, the intima media thickness is around 600 micrometer in the FGR group, while the AGA group, which is about 30 weeks now, is coming to around 500, 550 micrometer or so. And the wall thickness to lumen ratio is also significantly higher in this group. So that's the structure, morphology, but what about the dynamics in the preterm population? So the first column is the FGR cohort, then the AGA cohort, third column is unadjusted differences, and then the last one is gestational age adjusted data. And again, you can see the dynamic properties are very different. The resistance, the stiffness, the pulsatility. Pulsatility essentially is the difference between the caliber of the aorta between systole and diastole, as you can see here, close to half of what is seen in the AGA cohorts. So this is, maybe I can show you a video. This is a sagittal view in the abdominal aorta, straight part of the abdominal aorta. And this is the liver. This is the ventral wall of the aorta. That's the dorsal part of the aorta. Pulsatility is measured in the ventral wall. The thickness is measured in the dorsal wall. So when I play this video, you can see here the vertebral column, vertebral bodies at the back, and you can see it's a very compliant vessel wall. And when you look at the FGR aorta, you can see how thick and bright and echogenic it is. And it's not really compliant. It moves with respiration, not with each QRS complex. So it gives you an idea that in this neonatal population already, these blood vessels are behaving like vessels of the elderly, something which you would see someone who's 65, 70 years old. It is a very sobering experience when you do these ultrasounds. Now, last week, there was a question about, there's not much data on the right heart, and that is true. A lot of work is focused on the left ventricle and the aorta. So this is our 2019 work. We decided to look at the pulmonary artery indices and the right heart circulation. And this is pretty much the first and perhaps the only work looking at pulmonary artery. And the reason for that is just how the aorta is oriented. So the aorta is accessible for you to make an assessment at a 90-degree angle from the probe. While pulmonary artery is good for Dopplers, but not good for the morphodynamics because it's in line with your Doppler. So to get past that, what we did is we actually looked at the right pulmonary artery. So for those who are familiar with ultrasound, see here, that's the aorta here. It's a modified short axis view. And the right pulmonary artery goes under the aorta here. You can see here. The right pulmonary artery is going this way. The left pulmonary artery goes straight away. So we did some measurements. We got some special software loaded to our analytics and high fidelity imaging. And you can see here, the edges are so sharp. So that's the aorta there. And the right pulmonary artery is here in the middle and the left atrium is at the back. So we were actually measuring the thickness of the inferior wall of the right pulmonary artery. Okay. See, the picture is very similar to what I showed in the aorta. So the FGR right pulmonary artery is significantly thicker compared to what we see in the AGA cohort. When we look at the right heart function, so first column is the FGR, then AGA infants, then unadjusted differences and their significance, and then gestation age adjusted data and their significance. This is our 2019 work, and what we see is significantly thicker and less pulsatile pulmonary arteries in the FGR infants, significantly greater pulmonary vascular resistance, significantly dilated right ventricle, a poorly contractile right ventricle, and significantly slow to contract, right? So not only it contracts less, but contracts slowly. And whether it's primarily because the right heart is affected or it is in response to what is happening in the pulmonary arteries, perhaps it's a combination of the two. Now, the different ways of assessing arterial health. I talked a little bit about the use of ultrasound. In the newborn, because they really have a short neck, it's close to impossible to do thickness of the carotid arteries. So most of all the literature is on the aorta. But in adults and in children, carotid intima media thickness is something which is widely studied. So much so that people have used to evaluate changes over time. So once you have experience of the technique over such a long period of time, it tends to serve as an endpoint in clinical trials of medications, and also becomes a strong predictive value for cardiovascular disease events, much beyond what you say, okay, somebody's hypertensive or high pulse pressure and what might happen 20 years down the line. So this tends to be a stronger predictor because the technique, experience, and technology has become so advanced. So there are strong predictions for later on developing MI, stroke, or death by doing the carotid intima media thickness in, you can say, young adults, and they have this really strongly predictive of cardiovascular events 15, 20 years down the line. Now you might ask a question whether in pediatric population people are doing similar things. So only very recently, right? Double-blind placebo-controlled RCT looking at 214 children ranging from 8 to 18 years with familial hypercholesterolemia. And what they showed was after 2 years of therapy, the carotid intima media thickness was decreased, whereas in placebo therapy, it kept on going. So this is perhaps the only study I could come across where the measurements in the blood vessels, no, this is non-FGR cohorts, but it proves the point that more and more vascular measurements are being used as, in clinical trials as endpoints, especially where trials which are doing some intervention study. That's very common in adults, but and certainly it's not the case in newborns as yet, but in pediatric population, things are kind of catching up. Beyond the ultrasound, a lot of people use pulse wave velocity. Essentially, it measures the time and distance between the carotid and femoral arteries. If the arteries are thick, then the pulse wave velocity is fast. And the reason why the case is because the elastin has been replaced with collagen, so that makes the arteries very stiff. And the reason why this is very attractive to researchers is because in multiple guidelines and large-scale longitudinal studies, Baltimore study and the European Society of Cardiology guidelines, it has been shown to have a very strong predictive value for later on cardiovascular disease complications, much more than what would be ascertained by, say, okay, measuring blood pressure every time the patient comes. And its relation with birth weight is very inverse. So making this particular measurement, those who can do it, you can use it as a diagnostic link that, okay, I'm looking at a cohort of low birth weight young adults who were born with a low birth weight and their blood pressure is high. And every time they come to the clinic, I can use pulse wave velocity assessment and join the dots to say, okay, that's something which is interesting even before they become clinically hypertensive. And this relationship between birth weight and artery stiffness, as I mentioned earlier, it's across age groups. So from newborns to at least 30-year-old data I have, which is very strong data. And again, as I mentioned, it's really because the elastin synthesis comes to a halt with uteroplacental insufficiency, and all the elastin which deposits in the arteries is in the perinatal period. Once you're born, then the deposition of elastin in the arteries slows down immensely. Again, goes to show that what happens in fetal life cannot be reversed, and you will live with the consequences of what you are born with. So essentially, these infants are born with what we call a low elastin reserve, and that cannot be like corrected after birth. So this elastin gets replaced with collagen, making it a very stiff arteries and low compliance. And of course, even as a normal individual, with age, the arteries become stiff. That's why a lot of people become hypertensive. So there is a natural, I would say, breakdown of elastin and replacement with collagen with age. But in this particular cohort we're talking about, this replacement has started before birth. So again, it's an amplified aging phenomena which starts early. So this makes this particular cohort a classic cohort where if you wanted to study if the vessels are becoming aged early, so a vessels, a newborn are behaving like vessels of a 60-year-old, then this is the population. So what I'm trying to say is the changes and the dynamic properties secondary to growth restriction get superimposed on the normal arterial aging which happens with age. The question really is whether you are hypertensive because your arteries are stiff or because you're hypertensive, your arteries become stiff. So people have looked at that in great detail in a way that whatever was initiated in utero gets amplified after birth. And once you look at longitudinal data of hypertension and arterial stiffness, it shines a light on precursor role of the arterial properties. In other words, arterial stiffness comes first, followed by hypertension. So if you're following a cohort over 20 years, you will start to see their arterial indices undergo a change on an average about 10 years before you will see that their blood pressure is in the hypertensive range. So the question is, if you know what is going to happen in the arteries much before they are clinically symptomatic from hypertension point of view, can you intervene and change the trajectory before they become clinically unwell? You might have seen this slide before. This is the cross section of the artery, and you can see here some changes start in the first decade, some changes in the third decade, second decade, and fourth decade. The issue is that along with the vessels, there are changes in the endothelium as well. So there is endothelial dysfunction and smooth muscle collagen alteration. So this is normal aging process. But as I mentioned, in the growth restricted cohorts, these changes don't start in the fourth decade. They start much earlier. And that is the problem, that what happens with aging is either amplified or it starts much earlier when they start. And in addition to that, our ability to change course reduces with time. So if there is timely intervention, maybe antenatally or early in neonatal or childhood age group, then there is some plasticity in the system. So you could change the trajectory. But as time goes by, the response to those same therapies might not be as you might see when you started the same intervention at 10 years of age, for example. This is some of our work which gives you a bit of a pathway of what happens. So of course, if you start with the aging of the arterial system, I've already mentioned what are the abnormal properties. It can cause distal changes. And I think Jay was asking about the renal effects. So sorry, Jay, we don't have, the study is complete. We have not been able to compile the data as yet, but certainly in due course, it will come. But thickened arteries transmit high pressure waveform to the microcirculation. Microcirculation in the brain, in the renal glomeruli, in the eyes, is essentially arterioles. So those arterioles are not designed to handle high pressure waveform. That has to be absorbed by the aorta. That's the question. But because the aorta itself is so thick, it passes on this high pressure waveform to the distal microvascular regions and they get damaged. It can also affect proximally, because if you are the left ventricle or right ventricle, and if you're contracting against an aorta or a pulmonary artery which is thick and stiff, then proximally you will have changes like hypertrophy or dilatation of the heart or diastolic dysfunction, or in extreme cases, systolic dysfunction as well. Now, how does it predispose to myocardial infarction? So this is some of our very recent work in which we looked at what happens to the coronary circulation in these newborns. Okay, so in a normal pregnancy, if you do fetal ultrasound, you should not be able to see fetal coronary arteries before 26, 28 weeks gestation. But in the IUG or fetus, you start to see them at about 22, 23 weeks gestation. And the reason is that the heart has become thickened, hypertrophied, dysfunctional, and has increased myocardial oxygen requirement. To fulfill that requirement, the coronary arteries get dilated so that they can supply blood into these myocardial muscle. And once these infants are born, then those myocardial perfusion issues and the myocardial hypertrophy issues, they don't undergo that a smooth transition as they should go. So essentially, the coronary arteries in the IUG or fetus are working overtime because the myocardium wants more blood and oxygen. So in these cohorts, when they grow up to become children, adolescents, young adults, the coronary circulation is working full throttle. There is no reserve. And if these people go to the gym and spend 3 hours pumping weights, and the myocardium wants more blood and oxygen, those arteries say, well, we are already working full throttle. We don't have any more reserve to supply that myocardium. So that puts them at risk of young adults getting MIs. That's our thinking. This diagram tends to explain why that might be happening. So why these arteries are becoming stiff? I spoke about elastin and collagen. I spoke about endothelial dysfunction as well. And there are other contributors like, renin-angiotensin system, high sympathetic tone, and the reactive oxygen species, and the data in animal models. So I work, my hospital is co-located with an animal lab, which really works mainly in the preterm lamb model. Again, they've shown that in the preterm FGR lamb, again, similar levels of arterial stiffness and thickness are noticed in those lambs as well. So this is some of our recent work looking at how this arterial aging, which is accelerated, how it puts them at risk of adult onset cardiovascular disease. The range of mechanistic links we have talked about, the reactive oxygen species, but mainly I really want to focus on renin-angiotensin-aldosterone system. And the reason I want to really focus on is because that's really the center of mechanistic links. And I know Jay and his group, they also published some work in Journal of Hypertension, I guess, in showing the impact of perinatal factors. So in terms of biomarkers, and what we have shown is very complementary work. And so those who are interested, please read these two articles and to get a good understanding of why things are going wrong. As I said, I work with colleagues who work in the sheep model, the mouse model as well, and they have looked at the peripheral blood vessels as well as the aorta. And the message from the animal world is exactly the same, that there is increased blood pressure, there is increased pulse wave velocity. They've looked at mechanical properties are altered, and there is endothelial dysfunction. So what you see in the human model, same things you see in the animal models. Now, the question really is, of course, we look at newborn babies, but what is happening in older, children. So the blood pressure is higher and intima media thickness is greater at 3 to 6 years age, 8 to 13 years of age, and also in young adults. And we are not the only ones who are interested in this. You can see there are fetal studies where the intima media thickness is higher at 32 weeks in fetal life. I described in detail about what are the parameters which have been seen in the neonatal age group. Look at the pediatric population from 3 to 6 years all the way to 14 years. And then look at the adults, higher systemic vascular resistance, higher augmentation index, and reduced aortic diameter at 20 to 25 years, increased pulse wave velocity at 30 years, higher BP and intima media thickness at 25 to 45 years. The list is unending. So a lot of data is cross-sectional, but some data is longitudinal as well. But the message is the same, that across age groups, adjusted for risk factors, adjusted for BMI, the vessels are affected, and people have been looking at it for many, many years. So this is how it starts, and there's a range of risk factors I spoke about already. Ultimately, the arteries become thick and impaired in mechanics, and they can affect the heart, and certainly can cause end organ damage as well. So why should we look at it? In adults, as I mentioned, it has been shown to have a strong predictive value of future events, and that opens up how to track them and possibly therapeutic strategies. So let's go very briefly through any treatments which have been looked at. So this is a study from Michael Skelton's work, who is in Sydney, and they looked at the supplementation with fish oil from 6 months to 5 years of age, so drops, and also looked at not only supplementation but dietary consumption of the fish oils. And they noticed the benefits in children and adolescents who were born FGR, so lower BP, lower thickness of the carotid intima media, and lower thickness of the aortic intima media. The link, as I mentioned, between birth weight and carotid intima media thickness is present, but that association was abrogated in those cohorts when they were treated with supplementation of fish oil. So there is some evidence that those things work. In terms of other things, key is improving nutrition, living conditions during pregnancy, between conception, early childhood. Breast milk intake up to 6 months of age has been shown, comparing exclusively breastfed versus formula-fed cohorts, that it has been and adjusted to everything else, very strong predictor that it will lower the blood pressure and it would change cardiovascular remodeling as well for the better. So that's important. And in addition to, as I mentioned earlier, if the baby is born growth restricted and then becomes like catch up overweight or obesity, that's a double hit, and those populations do really poorly. So children, people who work in pediatric populations, certainly monitoring childhood body weight and blood pressure are essential, especially if there is a risk factor at the time of birth that they were born small. And the American Academy and American College of Cardiology, they recommend screening blood pressure in patients with a significant perinatal history. But the specific mention of growth restriction is not included as a perinatal risk factor. We talk about, okay, prematurity or like perinatal loss. Those are risk factors, but growth restriction per se is not included as a perinatal risk factor. So people working with adult physicians need to be made more aware that this is something which they need to ask or look into. And certainly prevention is important. as if you compare two groups of patients who are hypertensive adults who had lower blood pressure versus hypertensive adults who were normal weight at the time of birth, the first group is difficult to control, many a times requiring multiple antihypertensive medications. And our feeling is that that is because their systemic arteries are remodeled in such a way that they're thick and stiff, and simply reducing the blood pressure or dilating them is not going to work. We need something which can change the architecture and improve the endothelial dysfunction, which happens in these cohorts versus non-FGR hypertensive adults. So they can't be managed in same way. So the data is promising, but not as yet sufficient to say, okay, every pregnant mother should start taking a capsule of fish oil. So, there is promising information, but not something which can be recommended routinely. But as I mentioned, breastfeeding for six months changes the cardiac architecture and lowers the blood pressure going forward within the growth restricted cohorts. So this is the study which looked at breastfeeding, and it showed that it lowers thickness of the carotid arteries, which was induced by growth restriction. And I talked about this this intake of omega-3 polyunsaturated fatty acids and how it can make an impact on lower blood pressure even in children 8 to 15 years of age. The last few slides looking at the effects of sildenafil in IUGR pregnancies, and of course in theory it's a very promising thing. The IUGR placentas or pregnancy complicated by growth restriction or preeclampsia, they have less nitric oxide release, so explains the rationale why somebody might be interested in giving sildenafil. So good in theory. So studies have looked at giving sildenafil, RCTs. They were looking at difference in weight at the time of birth, no difference on the main outcome of prolongation of pregnancy or weight gain. It does improve uteroplacental resistance. Remember, this is where the issue is, that the uteroplacental insufficiency leads to higher resistance in the placental circuit, so nutrition and food and oxygen cannot get through. So it does address that fact, but is not improving the neonatal outcome. So certainly good in theory, good in pharmacology, but not coming good in the clinical outcome. So possibly we need some refinement in dosage, or the time when we intervene. Are we intervening too late when the disease is set in? Even during fetal life, do we need to intervene earlier at 23 weeks gestation rather than 32 weeks gestation? So those things need to be sorted. And as I mentioned last week, we are in the animal model, we are looking at some ACE inhibitors and melatonin. But I just want to finish with this particular study, which is a very recent study, very interesting study. And it's a parallel group RCT study looking at 1,200 individuals with singleton pregnancies diagnosed at 19 to 23 weeks gestation, who the previous pregnancy was complicated by growth restriction. So that's the inclusion criteria. Okay. And they are dividing these 1,200 singleton pregnancies into three groups. One is, of course, the usual care as per institutional protocol, which is at the bottom. Then the second group is Mediterranean diet, and I'll talk about what that contains. And third group is the diet is the same, but there is a stress reduction program. Remember last week I had mentioned about mind over matter. A lot of this is to do with how stressed or how relaxed the mother is during pregnancy. So that part includes weekly 2.5-hour sessions and 1 full day session, but the no changes in diet in that group. Primary endpoint is what is the percentage of newborns who are born as FGR, and the range of secondary endpoints as well, looking at adverse perinatal outcomes in the mother, preeclampsia, preterm birth, mortality, low Apgar score, neonatal acidosis, and those kind of things. So this is the Mediterranean diet program they suggested: use of olive oil, small amount of walnuts every day, and face-to-face interviews with dietitians, weekly planning of meals with detailed menus, and encouraged to take whole grain cereals, vegetables, dairy products, fresh fruit. Looks onerous, but realistically, a lot of us would be eating these things on a daily basis, hopefully. This regimen is really, making it very systematically applied to that period of pregnancy. So, it's a the more audience with the dietitian, and, giving them further reinforcements that these are the things you need to eat. So that's the gist of the Mediterranean diet. And again, list of items in their serving size people can look at. So the primary outcome, they're looking at what's the percentage of growth restriction or less than 10 centile birth weight. So this is your standard care, which is about 22%. And for Mediterranean diet, significantly less compared to the standard group, and the stress reduction group also significantly less as compared to the standard group. So diet alone or no dietary interventions, but a stress reduction strategy, which includes meditation, discussions with the psychologist, and exercise regimen and all, without changing the diet, can also make changes to the outcomes. When you look at the adverse perinatal outcomes, again, 26% in the control group, which is the usual perinatal care, significantly less in the diet group, and also significantly less in the stress reduction group. When you look at the combination endpoints like severe growth restriction, which is less than third centile, and preeclampsia or preeclampsia, severe SGA and or preeclampsia and or preterm birth, or severe SGA and or preeclampsia and or preterm birth and or preterm and or perinatal death. Again, you can see here significantly different compared to the control group of standard institutional care. So essentially, there are interventions you can do, non-pharmacological interventions you can do during pregnancy, which can significantly change the health outlook of uh, the fetus and put them on a very healthy trajectory at the time of birth. So, as I mentioned last time, pregnancy is the new scientific frontier where interventions are being tested. This is something non-pharmacological human study with great, fantastic results. Just to end with about, as I mentioned, the central role of the angiotensin 2. So ACE inhibition is something which we are trying in our animal models, and it's more than an antihypertensive. It changes the structural arteries by causing remodeling, and also has an effect on endothelial um, dysfunction that's improved. So I'll skip through these slides, which are essentially talk about how the range of blood tests you can do, which can predict what is going to come later on. But just coming to the take-home message to say that a lot of this disease, especially hypertension, is subclinical. They are not, these cohorts are not monitored regularly in the GP clinic or a pediatric clinic. But important that much of this begins early in life, even before babies are born, and the clinical symptoms appear much later in young adolescents or young adults. And a lot of focus in adult populations certainly is or arterial circulation in terms of tracking, monitoring, prevention, interventions. And the pediatric cohort and the neonatal investigators really need to catch up with what is happening in the adult age group. So that is where I would end today's talk. Thank you so much for your time, and very happy to take questions.
Thank you, Arvind. That was a really fascinating talk, and I'm sure there will be a lot of questions. Is there anyone? I mean, you can just unmute and or raise your hand if there is any question. No. Sujit, yeah, please go ahead.
So much, Professor Sehgal. Excellent talk. I've learned loads. I had a question with regards to the sort of technical aspects of measuring intimal thickness, and also the sort of probe that you use. Do you just use the sort of sector probe for measuring the abdominal wall, just like what we do in a routine echo? And do you use sort of M mode for measuring the thickness? Thank you.
Arvind, you're muted. Please unmute.
Sorry. So yes, not the sector probe, but it's a high frequency probe which is needed. And yes, M mode is used. There are two ways of looking at it. We have a software which can do automated tracking, which takes away the human angle. What is important is in a lot of cardiology, people don't particularly appreciate that there has to be an ECG trace at the bottom of the video, because there's no other way you can pick up systole, diastole. So these measurements are done in diastole, and if you don't have an ECG trace, you'll be measuring anywhere. Other people who don't have a tracking software, they like I remotely mentor a researcher who's based in Sydney. I'm in Melbourne. So we agree on the points where we are doing the measurement. So two people agree on a set of points where we will put the caliper in the diastolic phase, and then we do independent measurements, and we of course intra-observer measurements, and then Bland-Altman relationships are calculated. That's a more roundabout way of coming to the same conclusion. But software these days, with a lot of new machines, we use GE, and we do a lot of offline analysis. We capture images live, but we do offline analysis. And the thickness which is calculated in the aorta, we look at the maximum aorta intima thickness, not the average, but the maximum thickness. So you would do 5 measurements and take the maximum measurement, and that is how it has been done since 2005 in the neonatal age group, in the neonatal population. So those are the technical aspects. But if you read the literature on aorta intima media thickness since 2005 onwards, there's plenty detail in those papers to answer any other questions which might come up.
Thank you so much.
Arvind, on the same ground, please could you let us know which part of the aorta you take the intimate media thickness on, and also if when you do a carotid intimate media thickness, which part of the carotid you do on?
So in newborns, they don't much do carotid intima media thickness because the neck is short and it is quite discomforting for the baby. They would just start moving around. So almost exclusively neonatal literature is on the aorta. Carotids, the earliest I have seen is 3 years, but not in the newborn period. In the aorta, it has to be the straight segment of the aorta before the branching, and it has to be a sagittal plane, and you have to, so it has to be 90-degree cut, in the sense it can't be angulated. So I would say before you see the branchings coming out from the celiac artery and the supramesenteric artery, so it has to be slightly proximal to that.
Thank you. Any other question from anybody on the call? Okay, I think. Can't see anybody raising their hand. Ahmed? Sujit again?
Sorry, another question, if I may. You know, the last study that you showed with this Mediterranean and very interesting. I was curious to to ask you, does your center sort of recommend, does the obstetric team or anybody sort of recommend that sort of intervention to your patient group?
Well, not as systematically as they have shown. Those things can only be done in studies. But we have a dedicated, so in the obstetric side, we have, you can say there are three types of clinics running. One is the standard uncomplicated pregnancy follow-up clinics. The second is the clinic which runs for fetal anomalies, congenital heart disease, omphalocele, and you name it. And the third is these kind of pregnancies which are complicated by growth restriction in the main, or preeclampsia to start with. And that is where we are focusing more on doing more sessions, antenatal discussions, counseling. So diet and that's where there is a study going on right now using melatonin versus a placebo. And in that setting, those discussions take place. We're not recommending this list of diets in particular. But look, there's nothing to say that we should not. I mean, all these things are commonly available, and in a large cohort of study where 1,200 patients were recruited, and it has been shown to be effective. The only issue is that in this study, of course, there is a recommendation, there is a follow-up, there are sessions with a dietitian which act as a reinforcement for the families to continue with that. And all of these recruit patients had an IUGR birth in the previous pregnancy. So that's one more reason for them to say, okay, I'll stick to this recommendation, and because if I can avoid a replica of what happened in the previous pregnancy. So those can be motivating factors in themselves, in addition to the fact that you are getting a regular audience with a dietitian and regular attendance with your midwife and obstetrician where these things are being discussed. So it's a package rather than giving the mother a list of saying, this is
Yeah,
what you need to eat and at the end of it.
absolutely. So much.
Thank you. Yeah, Ahmed.
So my question is kind of the same sort of inquiry that I made last week. So both talks, eye-opening and very convincing, and thirdly, stimulating, asking to change practice and do something about what we feel is very convincing. So let's say in one line, I would say when I'm doing my high-risk neonatal clinics, we are focused more on the development. Is there anything from a cardiovascular point of view that you have now added to current practice, or um, how are we taking this forward in terms of changing practice?
Yeah, thank you. So look, the challenge is that if the baby is well looking, from physical appearance point of view, the reluctance of the families to come for follow-up. I mean, my baby looks okay. If they do come and we have a plan or like a follow-up program to say, the two things I would certainly want to do regularly, maybe at a 6 months interval to start with, is blood pressure with appropriate size cuff, and urine dipstick to look at albuminuria. As those two things are going to give you early clues of organ involvement, and those could be launching pads to say, okay, what I need to do about it. Some of it can be is like the blood pressure issue is modifiable. So the last thing you want to do is if you see in the clinic there is a rapid weight gain happening, then that's something which you really want to stress. Okay, baby's blood pressure is tracking on a higher centile. So, what are you eating, and are there any dietary choices you're making which is causing this child to put on a lot of weight? And so that's something which is modifiable. And then of course lifestyle changes and all could be implemented sooner. As I mentioned, there's a lot of plasticity in the system early on. When you cross into the adolescents, horses bolted. And urine dipstick is also another very simple test and a clue to say organ involvement is already happening. A lot of parents who say, okay, my baby's blood pressure is higher, but he's not hypertensive, and if the blood pressure is high, are you going to do anything about it? At the other end, demonstrating that there is protein loss happening in the urine is something which is a stark reminder that things are already getting wrong. You may not be hypertensive, but you already have changes you can see in the urine. So that's one solid evidence parents appreciate to say, okay, I need to change some course. In the study which I was mentioning, we are looking at protein loss in preterm FGR newborn babies compared to preterm AG babies to show that as a 2-point outcome. Is that the reason for continued failure to thrive in these cohorts during neonatal period? And second, if that is what the clinical team thinks, then is there a role for supplementation with a protein supplement? For example, if you go to the gym every day for 1 hour, they say you need protein supplementation either half an hour before the gym session or within half an hour of completing the gym session, because in that heavy exercise, a lot of protein breakdown will happen and you will have possibly protein loss in the urine. So where is that deficit going to come from? It's not going to come from eating a high fat diet or a high carbohydrate diet. You take a supplement which is being lost. That's the idea of protein supplementation. I mean, if you go to a pharmacy shop, you'll see a lot of recommendations of these supplements. And amongst themselves, amongst the range of choice, the most strongly recommended is whey protein, because it gets easily digested and gets assimilated into the body systems compared to high casein protein. So those are the concepts which are established in adult health style, and we want to extrapolate them to the baby pediatric time. But for those to happen, you need a follow-up clinic which is using blood pressure or microalbuminuria as an evidence to say that this is real, it's happening right now. And if you don't intervene early on, then that's not going to work.
And we noted the age of 4 years that for correlation. We tend to see neonatal clinics up to 2 years of age. So how early should I be? Although I know the whole thing is too oversimplified if I would say this is how I change practice. But let's say I want to see the urine dipstick and blood pressure and an unusual weight gain or an inappropriate weight gain. So is it 4 years you're looking at, or can I start doing it in my up to 2 years of neonatal clinics?
So the study I talked about, in which they looked at fetal aorta intima thickness and also looked at microalbuminuria. So that urine testing was done at 18 months. So 2 years is not early. That they did at 18 months because that was their follow-up clinic that was the end point of their baby follow-up clinic. And then of course they pushed them into the pediatric domain. So ideally, you would have a life course follow-up / intervention strategy where once they're not newborns anymore, they're not children anymore, they are adolescents and young adults, then somebody is picking them as they go between these age groups. They don't like fall between the cracks. But 18 months is when they demonstrated significant microalbuminuria. And although in our study we haven't done the tabulated data analysis, but I can tell you the albumin creatinine ratio, the normal is less than 3.5. I'm seeing values of more than 150 in the first week of life. So their nephrons are already affected, and the question is how long they stay affected. That's why we have two samples, one in the first week, then one in the third week of life, to see whether there is renal maturation happening, which is sorting this out, or even at the third week of life, the protein leakage is ongoing. But that study which I mentioned is a cross-sectional study at 18 months, but you could do it at 2 years. Nothing is stopping it to be done at 2 years of age.
Yeah, and blood pressure, that's something very, I mean, the reality of it is quite tricky to do in an 18-month-old or under 2 years old. The cuff size, the person doing it, a toddler. So do you think, would you advise me trying seeing blood pressures as well under 2 years?
Look, it is challenging, and that's why I mentioned, even if so you get a higher reading while the baby was thrashing around, you yourself would not believe it, that the baby was so active or crying, and how do I? So those challenges are there, and that's why I say, a demonstrable test like a urine protein is something easy to do. It's something which parents can see, they can rely on to say, okay, there is this evidence which tells me that some end organ effects are happening. But the question is, blood pressure measurement is logistically challenging, but still doable, and maybe one reason why this has not been done so regularly or religiously is, you rightly pointed out that appropriate size cuff, or a baby who's otherwise wants to run around the clinic. But if we don't overcome these logistic issues, then we will never have that data. So the blood pressure in the newborn period is higher in FGR newborns compared to AG newborns, but it's not hypertensive um, like thresholds. That pattern sets up very strongly at 4 years of age, and it's not happening suddenly. If there were enough dots to be applied from 1 month of age to 6 months, and so you will see that among centiles, this blood pressure is gradually going up, and by 4 years of age, it's well established that, okay, now I've taken a path which is very different from my AG peers, and now nothing is going to bring it back. It's just we don't have that enough data in the first 4 years to say, okay, it's not setting established at 4 years. Actually, it's getting established much earlier.
Thank you. Amazing. Thank you.
Thank you, Arvind. I think it was, a set of two talks where has been really fascinating and actually eye-opening for many of us. And you know that I have been working on some of these issues for the last few years. But I think, we have to think of how to collaborate in the future and bring all these things together, all these, great minds across either side of the ponds. And I think this is where the future lies for the research around hemodynamics. And as you said, there is very little work around arteries and vessels. More work is around heart and echoes, etc. So I think the time has come that we should think of how to collaborate around it and bring up all these studies together. So I think if there is no further questions, we will close the talk today. But I think the chat will continue in our group, I'm sure. And if there is any major questions or anything we need to, we'll reach out to you, if that's okay with you.
No problem. Look, thank you for the opportunity. It was a pleasure to talk to your group, and a lot of stimulating questions for me as well to do more and look into this a bit more in detail. So this urine work I'm hopeful that we would be able to finalize data analysis by the end of April, and maybe before end of year it should be presented or coming in print somewhere. If it does, then I'll be happy to send you a link so to see
Absolutely.
how we can build on what
Yeah.
we've shown. Yeah.
Thank you. Ahmad, do you want to close?
Professor Sehgal, thank you very much. Both your talks were the future, they're just amazing. I just found these words of yours really inspiring. Pregnancy is the new frontier of exploration. So thank you very much for speaking to us. And as Jay said, collaboration in future, and I'll probably